All right, we're jumping straight in today. No long intro. We are shifting gears into full revision mode.
Exactly. Think of this as a viva voce session. High yield, rapid fire, facts only.
Yeah, this is for you if you're a plastic surgery resident, a registrar, anyone staring down the barrel of your board exams, especially the FRCS.
That's right.
Today's topic is pathologies and congenital abnormalities of the head and neck. We're hitting three key areas that always come up: fibrous dysplasia, neurofibromatosis, and dermoid cysts.
And these are topics where, the underlying pathology really dictates everything. If you don't get the cell biology or the embryology, you will fail the station. It's that simple.
Okay, before we start the interrogation, quick housekeeping. If you find these sessions useful, please take a second to rate the show. It helps other trainees find us.
And leave a comment if there's a specific topic you want us to cover next.
Most importantly, and listen up here, if you want our Journal Club deep dives or the clinical cases episodes, you need the premium subscription.
Yeah, we can't do the really detailed case breakdowns on this feed. That's all in the premium.
So go get it if you want the whole package. Okay, let's get to work. First up, neoplasia and hyperplasia of the bone. Let's talk fibrous dysplasia.
Ready.
Okay, exam setting. I'm showing you a CT of a jaw lesion. I ask you to define fibrous dysplasia. What's your opening line?
My first sentence would be, it's a rare, non-neoplastic benign bone disease.
Good.
And then I'd immediately clarify the pathology to show I get the mechanism. I'd say, despite the name, the lesion is osseous, not fibrous. It's an abnormal proliferation of bone-forming mesenchyme.
Osseous, not fibrous. That's a great distinction. What's the specific cellular defect happening there?
So the defect is really in the maturation process of the bone. It basically stalls at the woven bone stage.
So it never becomes...
It fails to mature into strong, organized lamellar bone. You're just left with this immature, weak woven structure.
Right. And how does that present clinically, in the head and neck specifically?
It's usually an enlarging mass, typically in the maxilla or the mandible. And because it's this expanding bone, you get, significant mass effect.
Leading to things like?
Cranial nerve compression, proptosis if it's near the orbit, or severe malocclusion.
And is the growth indefinite? What's the timeline?
No, it's typically progressive until skeletal maturity.
Okay.
So you'd expect it to stabilize around age 30.
And what about malignancy risk? Do you need to mention it?
You absolutely have to. It's generally benign, but you must say that malignant transformation occurs in about 0.5% of patients. It's rare, but it's a known risk.
Okay, classification. Standard follow-up question. Monostotic versus polyostotic.
Just like the name suggests, monostotic involves a single bone. In the craniofacial skeleton, that's usually the frontal bone, the sphenoid, or the maxilla.
Right.
Polyostotic, of course, involves multiple bones.
Now, if you have a patient with polyostotic disease, there's a syndrome you have to be thinking of. What's the classic triad?
McCune-Albright syndrome. You're looking for McCune-Albright. It's in about 3% of polyostotic cases.
And the triad is?
1, the polyostotic fibrous dysplasia. 2, precocious puberty. And 3, café au lait macule.
Anything else associated with it?
Yeah, it's a big endocrinopathy. You can also find hyperthyroidism or pituitary tumors.
Okay, let's stick with syndromes. I show you a kid, multiple areas of dysplasia in both the mandible and maxilla. Looks aggressive. What's the diagnosis?
Cherubism.
And why is getting that diagnosis so critical for your management plan?
Because cherubism, while it's a familial fibrous dysplasia, it's autosomal dominant, the crucial part is that it is self-limiting.
It regresses on its own.
Exactly. It regresses spontaneously. If you operate on that kid, you're doing them a massive disservice. You leave it alone, and it resolves with no deformity.
Perfect. The classic do not touch lesion. So back to standard fibrous dysplasia, when do you operate?
You intervene when function is at risk. So we're talking optic nerve compression, diplopia, severe malocclusion. You don't operate just for cosmesis. There has to be a functional threat.
And the surgical approach, what does that involve?
It's resection of the abnormal areas. The real challenge is the reconstruction. You're left with these big defects that might need calvareal bone grafts, maybe alloplastic implants.
And if the dead space is too big,
then you're looking at free tissue transfer to fill it.
Any medical management options?
There's some evidence for bisphosphonate therapy, but really, surgery remains the mainstay for any functional compromise.
All right, pass on fibrous dysplasia. Let's switch. Topic 2. Neurofibromatosis. Give me the overview.
Okay, so neurofibromatosis is a group of genetic disorders. It predisposes patients to Schwann cell tumors. It's autosomal dominant, But, and this is a key viva, 0.50% of cases are spontaneous mutations.
So no family history doesn't rule it out.
Not at all.
Okay, examiner asks you to compare NF1 and NF2. Rapid fire.
NF1 is von Recklinghausen's. It's the common one, about 1 in 3,000 births. The mutation is on chromosome 17.
And NF2.
NF2 is central neurofibromatosis, much rarer, like 1 in 25,000. The mutation's on chromosome 22.
Quick memory aid for the chromosomes.
For NF1, I just remember 17. For NF2, I think 2 and 2, chromosome 22.
Okay, let's drill down on NF1. Diagnosis is clinical. You need 2 or more features. List them for me.
Right, you have to be systematic. 1, 6 or more cafe au lait macules with the size criteria, over half a centimeter in kids, 1.5 in adults. 1, 2 or more neurofibromas, or just one single plexiform neurofibroma. 3, axillary or inguinal freckling. 4, an optic glioma.
Halfway there.
5, 2 or more Lisch nodules. Those are the iris hamartomas. 6, a distinctive osseous lesion like cortical thinning. And 7, a first-degree relative with NF1.
You mentioned osseous lesions. What are the big orthopedic associations?
You see scoliosis and kyphosis a lot, but the really specific ones are congenital bowing or pseudarthrosis of the tibia.
Okay, quick point on NF2. What's the one thing you have to say? The hallmark feature.
Bilateral vestibular schwannomas. That's the headline for NF2.
Good. Let's talk about the scary stuff. Malignancy. What are we worried about in NFF?
MPNST, malignant peripheral nerve sheath tumors.
What's the lifetime risk?
It's less than 10%, and they usually arise from within a pre-existing plexiform neurofibroma.
So what are the clinical red flags? When do you get worried?
Pain and rapid growth.
Yeah.
A stable neurofibroma that suddenly starts hurting or getting bigger needs an urgent workup.
And that workup?
A PT scan is great to localize the area of highest metabolic activity. Treatment is aggressive surgical excision, but the prognosis is poor.
How poor?
The 5-year survival is somewhere between 16 and 52%. It's not good.
Okay, let's talk about surgery for the benign but problematic plexiform neurofibromas. Why is this surgery so difficult?
The bleeding, it's just incredible. The tumors are ridiculously vascular, and the bleeding is often refractory to normal electrocautery. The vessels just don't clamp down.
So what's the plan, intraoperatively?
You need a solid plan. Hypotensive anesthesia, definitely. Invasive monitoring. Cell salvage has to be ready to go. Some people even advocate packing the wounds open and coming back in 48 hours for a delayed closure.
And what do you tell the patient about the outcome? This is crucial.
You have to manage expectations aggressively. You tell them surgery addresses the bulk, the deformity, but recurrence is the rule, not the exception. The skin has no elasticity. It just stretches out again.
It's a temporary improvement.
Very much so. It's a constant balance.
Anything on the medical front?
There are some trials looking at imatinib, but for now, surgery is what we have.
Let's focus on a craniofacial specific for NF1, orbitopalpebral neurofibromas. What's the key bony finding?
It's the dysplasia of the sphenoid wing.
And what does that cause clinically?
It allows the temporal lobe to herniate into the orbit.
Right. And you get...
Pulsatile exophthalmos. The eye literally pulses.
How do you manage that?
It all depends on vision. If vision is preserved, you debulk the tumor and reconstruct that sphenoid wing, maybe with a calvarial bone graft.
And if vision is already gone?
Then you're looking at an orbital exenteration. You have to remove the contents of the orbit.
Okay, final topic. Let's move on. Unclassified craniofacial abnormalities, specifically dermoid cysts. Start with the simple congenital ones. What are they?
They're a displacement of dermal and epidermal cells into embryonic fusion lines. Usually see them in the superolateral orbit or forehead.
How are they different from an inclusion cyst?
Dermoids contain dermis and skin adnexa. So, hair follicles, sebaceous glands.
And treatment?
Complete surgical excision. You have to get the capsule out intact.
Yeah.
Usually through a supratarsal incision. They're typically deep to the periosteum.
Okay, now for the trap question. The examiner asks you about a nasal dermoid. Why do you immediately need to be more cautious?
Because nasal dermoids are a completely different beast embryologically. They carry a significant risk of intracranial extension. You cannot just cut one out without imaging.
Okay, walk me through that embryology. This is a pass-fail point right here.
Right. So during development, you have a little fontanelle called the fonticulus nasofrontalis between the frontal and nasal bones. And there's a prenasal space.
And the dura gets involved.
Exactly.
Yeah.
A little projection of the dura extends through that fonticulus and actually contacts the overlying skin. As the face grows, that dural projection is supposed to separate and pull back into the cranium.
But in a nasal dermoid,
It fails to separate properly. So as the dura retracts, it pulls attractive skin of ectodermal tissue back with it.
so you have a skin-lined tract going from the nose potentially up into the brain,
That's the danger. It can go right through the foramen cecum into the cranium.
which is why we image. What are you looking for on a CT scan?
You're looking for a bifid cristagalli or a patent foramen cecum. Those are bony signs of an intracranial tract.
And an MRI.
The MRI shows you the soft tissue. It'll show you the tract itself and how far it goes.
And if it does go intracranial, what's the surgical plan?
You need a neurosurgeon. It becomes a combined craniofacial approach, often requiring a frontal craniotomy to deal with the intracranial part safely.
Why can't you just, follow the tract from below and ligate it at the skull base?
Because incomplete excision is a disaster. It leads to infection, meningitis, osteomyelitis. You have to get the entire tract out.
So, recap on nasal dermoids. Always suspect an intracranial connection, always image, and if it's there, call neurosurgery.
Precisely. That is the safety check the examiners are looking for.
That brings us to the end. So we've covered the osseous, not fibrous, nature of fibrous dysplasia and the McCune-Albright triad.
We hit NF1 versus NF2, the bleeding risk in plexiforms, and the mechanics of sphenoid wing dysplasia.
And we finished with the embryological trap of the nasal dermoid.
Honestly, if you can clearly articulate the embryology of the nasal dermoid and the plan for bleeding in an NF patient, you're performing at a very high level.
Those are the details that separate a pass from a fail.
Absolutely.
Okay, one last thought to take away with you. We talked about how NF1 surgery is often temporary with high recurrence. There's a real ethical balance there.
It's true. When you're treating a progressive disease where the tissue itself is the problem, how do you manage expectations? The best surgical result might only last a short time.
It brings up big questions about timing and quality of life that go way beyond just the exam question.
Something to think about.
Definitely. And remember, if you want the Clinical Cases deep dive where we apply all this to real scenarios, you need to subscribe to Premium.
That's where the rubber meets the road.
Good luck with your revision. We'll see you in the next deep dive.
Study hard.